serious muscle injury, bicarbonate and mannitol is not found to be beneficial in these patients, for example. So further studies on drug-induced rhabdomyolysis are needed. So we can say new things. Thank you very much.
Thank you very much, Dr. Vural. Any questions? He works in the emergency department of Sydney Medical School in Sydney, New South Wales, and is also the toxicologist of the Western Sydney Toxicology Service. And we have the great pleasure that he will talk about the new N-acetylcysteine regimen in acetaminophen poisoning. This is a very difficult theme because there are so many protocols now. In the past we have just one, it was easy, and now it's too much complicated. So
by the end of this talk, you'll only have one again.
We're happy. Thank you, Naren.
Thank you. Thank you for inviting me to speak about acetylcysteine regimens. I don't know about your country, but we've stopped calling it N-acetylcysteine in the last couple of years. It's now just acetylcysteine. I don't think I need to remind you about the metabolism of paracetamol, but I just get you to keep your mind about NABQI as the hepatotoxic metabolite, which is formed from P450 enzyme metabolism, which then is detoxified. This is the traditional model of paracetamol metabolism and how it's detoxified. NAC is an acetyl moiety that is hitched onto the amino acid L-cysteine. So you can see the colored bit is the acetyl bit, and the rest of it is your normal cysteine molecule. What does it do? It's true, yes, it provides self-hydral groups and promotes the creation of glutathione, but it also has other properties like scavenging antioxidants and provides some level of protection against free radical formation. But what started happening once N-acetylcysteine became a very prominent player in the antidote for paracetamol poisoning in the 70s is we started seeing adverse effects to acetylcysteine in the early 80s. And predominantly it was GI and skin. They were the predominant adverse reactions that people were seeing. When it started being given intravenously, the commonest error was somebody ordering it tenfold errors. So instead of giving 17 grams in a liter, they gave 170 grams in a liter. And these were not thought to be anaphylactic, and I'll tell you why in a minute, but non-anaphylactic, but anaphylactoid and non-allergic, so they were termed NAAR or NAR, and I'll talk about what that is. This is probably the first fully sort of going through every single adverse reaction paper, important paper to read by Parkeroven in 2008. And it talks predominantly about people getting abdominal effects, and then skin effects, and then other things like respiratory stuff. So it's the stuff that you're seeing already in your units whenever you see NAR. Why does NAR happen? One thing became clear, it was not IgE mediated, which is why it was not thought to be anaphylactic, and so thought to be anaphylactoid. Although the effects look very similar to anaphylaxis. And it had nothing to do with whether you'd had acetylcysteine before. So it's not like some kind of foreign protein, like let's say the sting of a bee or some kind of venom or some other foreign protein, that if you'd had it before, you were more likely to get it again in an IgE-mediated way. This was not like that. You didn't have to have previous exposure. The other thing was that there was histamine release, but tryptase levels did not go up, suggesting that it was not mast cell release of this kind of effect. When they did levels of NAC, so this is acetylcysteine levels as mapped across time, you'll see, because we give a huge bolus dose, and then the levels go away after that first 15 minutes to an hour. And then if you match that to what was happening to histamine levels, about, depending on how fast you gave that first one, if you gave it in 15 minutes, like the original papers, then your histamine levels rose soon after that. And so that's why people often saw that reaction when the second bag started. That was the commonest time. Is, you know, I put up the second bag and the person had an effect. So that's what the nurse would come and tell you. And people were starting to blame the second bag, but it was really clearly starting to think that it was the first bag. This is another excellent paper that Steve Waring did also in 2008, where he confirmed, and it was already suspected, that if your acetylcysteine levels were low, that you were more likely to get an adverse reaction or a NAR reaction to acetylcysteine. But if your levels were high and you really needed the NAC, then the chances of getting a reaction were low. And this started to happen because in Europe and certain places, particularly Denmark and other places, they were giving NAC to everybody. Doesn't matter if you took 5 tablets or 100 tablets, everybody was getting NAC. And it's almost happening like that in the UK now. So this is the standard regimen that everyone's been using for the last 50 years or 40 years. There was a paper done which compared 15 minutes to 60 minutes, and they didn't find a statistical significance. That was done by Fergus Kerr, was the lead author. They compared 15 minutes to 1 hour as the first infusion dose, and they found that there was no difference, or the difference was too small and they couldn't find it to be statistically significant. So I'm assuming the majority of you are using this. Is anybody not using this regimen? Okay.
You're the only one.
I'm the only one. I'm not the only one. I'll tell you who else is using it in a minute. So with those histamine levels, those acetylcysteine levels, it started to become clear that probably that reaction is happening because of the very fast first bolus dose. So the SNAP study, probably the first big study to tackle a different thing. First time somebody had changed acetylcysteine in 30, 40 years properly. And here they gave acetylcysteine in 2 bags over 12 hours. The total dose was the same, 300 milligrams per kilogram, but not in 20 hours, but in 12 hours. They found a big difference in the NAR rates. It went down from 30% pre to almost 5% afterwards. That study was a little bit complicated because they mixed up the whole NAR situation with the vomiting and the gastro situation, the use of ondansetron. So it was a little bit hard to differentiate the whole gastro versus anaphylactoid reactions in that. Now this is called the SWAMP protocol of what we did in Australia. This is not, the word SWAMP is not published anywhere, not known to anybody. It was the word that we just used in-house because it was a handful of hospitals in Southeast Australia that were doing this. Sydney West, that was my hospitals. Austin Hospital in Melbourne, where the chief, one of the chief authors works at, which is Anselm Wong, and the Monash Centre protocol. So the SWAMP protocol, you don't have to call it that because nobody else does, but it was just because those were the hospitals in this study at the beginning. All we did was just merge the first and second bags. That was it. So 150 and 50 became 200. 1 hour and 4 hour merged to stayed as 4 hours. That third bag remained the same, 100 per kilo over 16 hours. So the first bag became 200 per kilo over 4. The second bag became 100 per kilo over 16. So the first 2 bags were merged. Total dose is the same. Total duration is the same. 300 milligrams per kilogram over 20 hours. And we're going to show you some data on that. This is our data from Western Sydney. The chief author for our paper was Richard McNulty, who's one of our clinical toxicologists. He and they worked very hard to make sure that they captured everybody. It was a retrospective study, so that's a limitation, but we're pretty sure we didn't miss any doses of NAC. There was a 66% relative reduction in adverse events if you switched from the 3-bag to the 2-bag. If you just compared severe effects, so that's people who became hypotensive, had breathlessness or any kind of skin swelling, there was a 77% reduction for those people, relative reduction. And there was a similar 60+% reduction in the use of anti-allergy medications like antihistamines and steroids. Now, if you compare that study and do a meta-analysis of other similar studies, so Anselm in Melbourne did his own study. That's the one that's number 4 on the list, that's Wong. Very similar results to ours with the odds ratio 0.39 versus 0.32 for us. Very similar, a repeat study done in Denmark just recently by Daoud, that's the study at the top, also 0.36, so 3 times less chance of having an adverse reaction if you use the same 2-bag protocol. So all of these studies have done exactly the same. They have merged the first 2 bags. The only study that's done something different is Bateman, which is the SNAP study I showed you, which is the 2 plus 10. Okay? But Daoud, McNulty, Schmidt, and Wong have all done the same thing, pretty much. Here is the forest plot on that, on those papers. Now, if you look at this, I don't think any of you should be using the 3-bag NAC ever again. You're going to give me why?
No, because all these are side effects, but
Yep.
what is about the efficiency? That's the problem.
Yep, that's right. So all of these are about exactly that. So we haven't got enough data on the whether there's an inferiority issue. So far, we've been using this protocol in Western Sydney and in Australia for 5 years, and we haven't seen a change. It's not inferior to the previous because the dose is the same and the duration is the same. But certainly, adverse reactions are better. So what are the other advantages to this? The main issue is that there's less interruption between bags. So you have one less bag change. And often nurses will start the first bag. Once one finishes, by the time they start the next one, there's a gap. By the time you chase them down to come and put up the next bag, you've lost a bit of time without NAC. So less medication errors and preparation time. Now, to get this change in protocol across the countries has taken a long time. So Australia and New Zealand changed to the 2-bag NAC in 2019, and so did the Swedish Poison Center. I'm not sure if anybody else has. I know California is still on 3-bag at the moment, and I assume France is as well. I'm not aware of any other places, but these 3 Rocky Mountain has changed? Oh, okay, great. Oh, okay, thanks. Great. And so what we're waiting for are these non-inferiority studies to see whether there's any difference, but I think it's unlikely at the moment. What's coming down the track is NAC Stop. NAC Stop's a study we're just about to publish shortly. Sorry, NAC Stop's been published, and the double NAC and a couple of other. The NAC Stop 2 is the one we're about to publish. NAC Stop was published last year, where for low-risk paracetamol toxicity, we are stopping NAC at 12 hours. So these are people with single ingestion. The LFTs are already normal before you start NAC, and then at 12 hours, you repeat the LFTs, and the paracetamol's under 20 milligrams per liter, and it's at that point you can stop the NAC safely. So that's been shown to not cause any change in hepatotoxicity or death. So we think that in these low-risk patients, that you can probably stop NAC at 12 hours. NACSTOP 2 is still to be published, so I won't talk about that because Ansam should talk about that. It's his paper. The other thing that we're doing is double NAC. I know this is practiced in California and other places as well, and that is if at any point your result is double the nomogram line. So this is the nomogram line that we use in Australia, which is the same as in the US. So it's 150 at 4 hours. Let's say at any time, say at the 10-hour mark, your level is double the nomogram line. At that point, you should double that second bag. The first bag's given, that stays at 200 milligrams per kilogram, but that second bag is doubled. So we're thinking at the moment, the thinking behind that is that we're not actually giving NAC based on the dose ingested. It's based on weight of the patient. Now, if you say 1 mole of NAC counters 1 mole of paracetamol producing NAPQI, then really for a 70-kilo person, then that fights about 20 grams of NAC. So if someone takes a massive ingestion, more than 30, 40 grams, then you're probably going to need double or more NAC. That's the thinking behind that at the moment. Still controversial, not widely accepted. It is in the Australian guideline as of last year to double the NAC if the level is double the line at any point. Other things, there are other novel approaches that are being thought of all the time. I'm only putting dialysis there so that people don't forget it. There's nothing novel about dialysis. People have been dialyzing paracetamol for a long time. I've just put it there so that people don't forget that paracetamol is a dialyzable drug, and XStrip has got guidelines on that already. Fomepizole, I don't know if anyone's used fomepizole or 4-methylpyrazole, but it actually, unsurprisingly, works because if you remember back to my very first slide, our old friend that metabolizes paracetamol into NAPQI is our good old friend CYP2E1, which also is the same enzyme that's metabolizing ethanol and methanol and ethylene glycol. Now these are all, there's isolated case reports, there's not a lot of data on these other novel approaches. Metformin is thought to do some superoxide scavenging. Methylene blue may also have some effects on the electron transport chain, which may help. And another drug which I can barely pronounce, which is calmangafodipir, is on phase 1 trials right now as being a promoter to mop up superoxide radicals from NAPQI-induced hepatotoxicity. So it could be down the track, say in 10 years' time, that you'll be giving NAC with calmanga drug. That's a possibility down the track. Thank you.
Thank you very much, Naren. Any question from the floor? You have many questions. We'll start.
Okay, so thank you so much for this presentation. It's very interesting. I have 2 questions, basically. I know that when it comes to the side effects, though we are giving the same dose and the same duration, but in fact, you are not giving the same rate. So in the case of 3 bags, we are giving 150 milligram per kg over 1 hour, whereas in the other one, you are giving around 50 milligram per kg per hour.
Yes.
Right? So basically, the dose will be definitely less. Maybe that's the reason why you have less side effects compared to the 3 bags.
Absolutely.
And already that study showed that there is no difference between 15 minutes and 1 hour.
Yes, so that was the study showing that there was not a huge difference in adverse reaction rates if it was given between 15 minutes and 1 hour. So it's 150 per kilo over 15 minutes, or 150 per kilo over 1 hour. I absolutely agree with you that giving the first bag slower, not at 150 per kilo per hour, is the reason why that you're seeing less NAC reactions. So the dose is slower, and that's why you're getting less reactions, because that was the reason for getting those reactions. We were giving it very fast. The other thing is, if we think about the way NAC regimen was devised in the 60s and 70s, these were given in Northern England and Scotland to people who presented quite late. They were not coming 1-2 hours after their overdose and saying, I've taken 50 Panadol, please save me. These guys were presenting later. So at that point, giving a big bolus of NAC to someone who's heading down hepatotoxicity road probably made sense. Nowadays, we're giving it to people, sometimes we're giving it to people who've taken hardly any paracetamol. And so I think that also plays into why we're seeing more adverse reactions in our current cohort of population as compared to that published during Prescott time and things like that. Yeah.
Yeah, but that's the same thing in the study where you said that comparison between the 3 bags and the 2 bags, and there is no significant adverse outcome, and you are advising for the 2 bags, right, instead of the 3 bags. The same thing, the studies did not specify what was the time of the presentation and how much the ingestion was.
Yes, so I haven't presented it here, but all of those studies have had matched demographics between the 2 cohorts and are very similar.
Okay.
Yeah. I didn't put that table in my talk, but yes, there is an extensive table in pretty much all those studies about the cohorts between the 2 bag and 3 bag being very similar. Yeah, but that's important. Yeah.
One question from Ritrak.
My question is really short. Are you going to do 1 bag?
Yeah, that's a great question. I think we're going to get there. It's taken us 40 years to get from 3 to 2. I think eventually we'll get to 1 bag. It will be 300 per kilo over 12 hours in 10 years. I'm pretty sure. Good question.
Yeah, I agree in the cases where it's not, the poisoning is not so severe. But what about if the patient is seen with delay? What about if there is already an acute liver failure?
Yeah.
So my questions, is the bolus important or not? And do you increase the dose of NAC or not in these severe cases?
Yeah, good question. I think in those people with either established hepatotoxicity or ones that present late, giving 150 per kilo over 1 hour versus 200 per kilo over 4 hours in that later presentation, I suspect there's very little difference in that. I think it's going to be okay. Because these guys present maybe 12, 20 hours there. So whether they get it within 1 hour or 4 hours is probably not as big a deal as the fact that they need more over a longer period of time, which is why in those scenarios with established hepatotoxicity, we are already doubling that 2nd bag. We are already doubling or tripling if the level is really high.
So you double if there is an elevation in transaminases?
Yeah,
even though the paracetamol concentration is low?
Absolutely, yeah.
Okay. Yeah. Any other question?
You can double or just give it for longer.
Yeah. Longer, okay. Any other question? Okay. Thank you very much for this very interesting presentation. And we'll move.
Good afternoon, everybody. And it will be short. It will be different. So I'm going to talk about the concept of are we ready to deal with any botulinum cases. So I will start with a small story, which has a regional or sub-regional importance, and then come with lessons learned, which is about 3 or 4 points. First of all, it was about 1.5 years ago. My colleague from a neighboring country called us and he said, "Well, we have suspected case of botulism. Do you have the antitoxin?" I said, "No, we don't have it. We don't have it because we didn't see any botulism case for like more than 20 years. He said, "Well, we have 1 case and we need," and he said, "Well, you can call others and maybe international centers or other countries or maybe WHO." Then they called me, they said, "Oh, it is not botulism." Then I was talking to my colleagues, "Shall we have some of this antitoxin? What about diagnosis?" They said, "Well, it's an old disease, we don't get it." And this year, a family of Egyptian family in Qatar. The father, son, and daughter were affected, were admitted. It was really a new cluster of cases that are really, we didn't see it for a long time. Many of our colleagues, they say, well, this is in the textbook. So they were calling each other, come, see, we have an interesting case, and we don't need to miss it, because we may don't get it for another few years. So it was diagnosed clinically as botulism toxins. They were Egyptians, and we know that Egyptians are maybe one of the most affected countries in our region, because they have what they call Shem and Nasim holidays, where they cook fish and make it in, they store it in special jars, where it's really anaerobic conditions, and it favors the growth of botulism. So we were investigating how to deal with this case. We don't have the diagnostic in our lab. We don't have the antitoxins. We have antibiotics and supportive, and some of them were intubated. And then we want the antitoxin. What shall we do? So I called WHO office, our regional office in Cairo, and they said, we don't have it. Okay, what about the headquarters in Geneva? Well, actually, it finished. There's an order, and it might take a few weeks or so. That was really a bad situation. And we know that Egypt has it, because Egypt always prepared to have some cases, and every year there is 100 vials coming specifically to Egypt. And then we use our, I would say, ways to let the family talk to the embassy, and the WHO officially coordinate, and eventually we succeeded to have it. A bit late, more than a week, and it has to be delivered by one person, by hand, and it was really difficult. At the same time, we tried to map the producers, the pharmaceutical companies, and we found the best is the Canadian company that Egypt bring their products from them. And immediately we called our embassy to bring 3 vials as soon as possible, and then we made some orders to have more stockpiles. So the lessons or the story is that we were alerted 1.5 years back. We didn't take it serious. We had it in Qatar this year, and we learned from it. And even though there is an Eastern Mediterranean poison net, with some of the colleagues here are member, and we were talking to them. They said, well, we don't have it. We have only the antitoxin A and B, and we discovered that it's not only locally, it's regionally, and even to internationally, we are not really prepared to deal with these cases. So the lessons from these issues is that we need to have the diagnostic capability in our lab in the hospital, the diagnostic capability in the public health lab, or food safety or environmental lab, to diagnose the food and the people. And also to have something in terms of protocol, how to deal with these cases, and also to make our colleagues, doctors and nurses and healthcare workers, aware of these cases and this disease and how to deal with it. Also, if we don't have it, it's not, because the antitoxin is very expensive. If we don't have it, at least we know where it is, or regionally in our region where we can find and order these antidotes. So from there, we took it serious, and we started some discussion internally and nationally. And also, we took that serious to our IMRO office with WHO in terms of mapping our region, and also identifying how many vials in each country, and then make it regularly reported. In case any country needs, we can provide them, even with cost, sometimes without cost. And in our case, Egypt gave it to us for free because it was affecting the Egyptian family. So the lesson or the message here is that we need to have it as a package. Increase the awareness of healthcare workers, decision makers, lab, clinicians, and even international methods or ways to order it. And we use the ICHAR, the International Health Regulation 2005, as a call for this treatment. So basically, I'm just raising the awareness is that although it is quite rare, but sometimes you will get it, and sometimes you get it in a big volume, not only 1 or 2, maybe 3 or more. So we were lucky to have 3. All of them survived, but took a long time to recover. But we were really worried about them. So they were, alhamdulillah, we had a very equipped intensive care unit. So some of them were the 3 of them were intubated, but some of them stayed 2 months. The father stayed about more than 2 months, but eventually they recovered. But it is really bad because we didn't give them the treatment initially. Otherwise, it would be speedy recovery. And this is basically what I need to say, increase the awareness, and thank you very much indeed.
Thank you. Is there any question? So if I understood, you have a project of mapping in the MENA region where the anatoxin are present, where the antidotes are present?
Yeah, we agreed with the IMRO office to start and do it with them together, so it becomes more official from IMRO and with our inputs in it.
Okay. Because I guess that in many countries there are no supply and no possibilities to get the antidote.
And at the
on
moment
time.
we are in the process of recruiting 12 vials for this year, minimum.
Okay. Any question? Thank you very much, and sorry for my mispresentation, and welcome to our Congress.
Thank you. I really appreciate it.
Okay, so I don't know if it will be here or somewhere else. Here, so the walls will be open, the two rooms, or not? Okay, thank you very much.
Welcome, everyone. Sorry for the delay. We ran behind a little bit, so I apologize. But we wanted to just close the main scientific conference with this ceremony. Archie, Dr. Hoffman, for the abstract. So we will keep this short, very concise. We have a few objectives. The first objective is to first have a few thank you remarks. On my behalf, I really want to thank the participants who persevered through our scientific programs, which are quite lengthy this year compared to previous years. I'm very happy with the attendance. You know, we had hoped to have a very vibrant and engaged attendance, and I think we did that. And this is not surprising considering our membership as well as IPAT's membership and passion for toxicology, which was very apparent. We thank you again for your volunteerism. All our speakers volunteered their time and money to come here and speak and participate, so we appreciate that. We also want to thank the company Literature that provided all the logistical support, and thank our sponsors, Toxins, Randox, Response Systems International, Turkish Red Crescent, and the company that markets N-acetylcysteine in Turkey. We also want to thank, on behalf of Minatox, our partners, IPAT, for their support and partnership, and look forward to future programs together and development of toxicology in Turkey and the region. Thank you.
Thank you very much. In the end of the 2 or 3 day, very nice conference, and we take note for this. Toxicology is very important part of emergency. So we will continue to contact, and thanks for Minotox speakers from all the world. They come and join us and share their experience. Very valuable speakers from all the world. It's a big honor for us to see you in Istanbul and to know you, and we hope we will be in contact for the future cooperation. I think this is very useful conference, and around 100 topic, more than 100 topic maybe. 200 participants, no, very much topic about toxicology. We speak about toxicology, everything about toxicology. We will be in contact for the toxicology journal and toxicology textbook and another topic together. And I think don't forget, did you give promise for the 2 years later again in Istanbul? Don't forget about that. Inshallah. And I want to invite all these valuable speakers to our big conference. IPAT, very big family, not only in Turkey, in the world. We are in like international society. So I want to invite everybody to international section of IPAT. And we have your detail and email. And we will be in contact. We will send you email from IPAT. And I want to thank my team, my college, and especially Dr. Behjet behind of me always. I am front, and Dr. Behjet come to conference after the very difficult time, and we didn't share this, but I think I should say, because in this difficult time, after difficult 1 week, he never give up from job and working and join us. I want to thank to Dr. Behjet again. Thank you. Great effort. Thank you very much. We have very nice memory with you, and I hope like this, you think like us for the future. Thank you very much.
Dr. Behjet, Dr. Gul, would you like to, Dr. Behjet, would you like to say something? Okay, for the sake of time. What about Dr. Hoffman? Can you help me with the oral abstracts and the awards?
Sure, absolutely. So Ziad, maybe you could actually pose with the person when they come up. But so we have a selected best oral research abstract presentation, and that presentation was acetaminophen poisoning resulting from repeated supertherapeutic ingestion, circumstances and outcome, Dr. Bruno Magarbain.
Oh,
At least stand up. Yes.
Do you want to take a photo with me? Come on.
I was looking for the camera right there.
What an honor. All right.
Okay, thank you. And our best, so the best oral presentation of an e-poster was the utility to test the salicylate level for all cases of paracetamol overdose, Dr. Ahmed Alabri.
Congratulations. The next award is actually a memorial award for one of our medical toxicology fellows, Dr. Saeed Al-Mazroui, who was enrolled in a medical toxicology fellowship in the US, at Emory actually, and then who was diagnosed with a brain tumor during the fellowship. And he actually succumbed to his disease, leaving his family behind, unfortunately, and leaving many friends in Oman and the Middle East, North Africa region, and MENA talks particularly. So in honor of his memory, we have an award that we give every year to someone who is passionate about toxicology and has served MENA talks. This year's Saeed Mazroui Award goes to Dr. Urine Gokta from Istanbul. Last but not least, we would like to thank our speakers with a small souvenir from this conference. And I'm going to actually read the name of the speakers. If the speaker is not here, we will just basically move on down the list and we will save their souvenir and certificate till after the ceremony. We'll start with Mr. Nabil Ahmed, Dr. Ihab Aki, Dr. Peter Agupnunu, if you guys give you a heads up so you can start walking to the podium. Dr. Faride Agul, Dr. Bashatal, you are here already. Dr. Ibtihal Lattas, Dr. Suad Labri, Dr. Khaled Laufi, Dr. Anwar Al-Awadhi, Dr. Hassan Al-Balushi, where's the camera? Dr. Jalal Isa, Dr. Badriya. Somebody can read, and then I can stand on the camera.
Aylin Arıcı. Avni burada değil. Ashish, you are welcome. Ashish, yes, Aylin, please.
I have to stand the same place. I'm gonna move. This way, please. Also this.
Ashish. Sen devam et. Sen devam et. Okay. Abdul Latif Alumi. Atim. Tamam. Abdul Kadir Gündüz is here. Okay. Amal El-Kozai. Amal El-Kozai. Not here. Okay. Andrew Nelson.
Andy Nelson.
He was here. Bruno, he's already here.
Andy's here.
And he's here. Bruno, you are here? You are still here. Bedriya El-Hatali is not here. She is here. Ah. Oh, she's here. Who is Bechet Al? This is mine. I'm here. Brad Morgan. In the morning he was here. Brand? Okay. Brad Erickson. He's traveling Istanbul, I think.
No, Brett was in New York. He did the phone.
In New York, not Istanbul. Charles Maki? Okay, he's here. Ahab Aki? Ahab? Okay. Edwin Kilburney? Charles. Edward? Eva, my friend? He is in Bosporus. Elia Harmonic? Elia? Eren was here. Gökdağ. Gülseren is not here. Gürkan Ersoy. Gürkan was here, yes. Gaylord Lopez. Not here. Jalal Alashi. Jalal not here. Okay. Hussein Hassan Iranian. Hussein Hassan. Okay. Hanna. Dr. Hanna. She was not here. Hassan Belushi. Hassan kim geldi? Hussein Hamoudi. Where is Hussein? Hussein Hamoudi. He's eating. Ismail Sabei. Not here.
We had put discussion to the end, but I think we've got time for a few questions. If anybody has any comments or questions about EVALI or e-cigarettes. Are you seeing this in Turkey? There's plenty of cigarettes. Don't need e-cigarettes. Not common.
I'll mention one thing that, so I took care of a number of these patients, and because they were getting their THC products literally, I mean, they would say, yeah, you know, Johnny 3 houses down, he's the person I go to get my liquid that I use in my electronic cigarette. I would actually counsel them if they really needed THC to just smoke cannabis as opposed to using the electronic cigarettes. It's not the usual advice I would give someone as a physician or as a medical toxicologist, but I felt it was probably better that they use, if they're going to use drugs, that they use it in a way that's safer and than a way that was less safe in these cases. So there was some interesting conversations I had to have with patients about their drug use during this outbreak.
So on that point, Trayvon, we found that in Australia that people who were never cigarette smokers had started taking this fashionable sort of smoking habit up. Is that what you're seeing? And were they tending to be the ones who are more on THC type, or because people shouldn't just suddenly start going on nicotine, you would think?
Yeah, so that actually brings a lot more to nicotine marketing. So these electronic cigarettes were overtly marketed as an alternative to smoking, but were subversively marketed in a way that was attracting new, young nicotine users, primarily teenagers, in very fashionable ways. And as you can imagine, if you get a teenager addicted to nicotine, you've got a customer for life because nicotine is an addicting substance. And so yes, so we were finding, if you were demographically, most of the patients involved were young men, usually late teenagers through early 30s. And many of these people would not smoke cigarettes. They were electronic cigarette users. That's how they took their nicotine, or transitioning to their THC products. But yeah, it's an interesting concept in marketing that these products were marketed towards a younger audience to get new nicotine users, and then many of these ultimately went on to using THC as well.
Thank you.
Thank you. Excellent talk. I'm emergency physician and clinical toxicologist from Oman. One of the things I'm not sure if it came across to you is, since 50% of my customers are actually pediatric age group, did you come across like that nicotine syrup being ingested by kids? And do you have any data for that? Because it's, when I was in US in San Francisco, we actually came across some of these cases where the kid got into his dad nicotine and that sort of thing. So
yeah, so we do see these cases where, so these, you can imagine if this were smaller, you buy your nicotine liquid, your e-liquid to put into your device, you leave this container around somewhere, or a child can get into it and ingest a lot of nicotine and be quite ill. And so yes, that does happen. And so,
like data for that?
I would imagine we could get that data. I haven't looked specifically for that data, other than I know that has happened. I am aware of at least case reports. There may be case series as well. But that is certainly something that we talk about, and in kind of dealing with harm reduction, when we know of people who are using electronic cigarettes, particularly of their refillable tanks. So many of the products you can just go buy a cartridge that's got liquid in it, and you just put it in the device and use it. But many times you just get the liquid and you can refill your container. Those are the ones where you really can get into trouble, because that container can just be left around and a child can get into it. And it's a lot of nicotine. This is actually an interesting piece with the electronic cigarette use, is as opposed to smoking a cigarette where you have to light the cigarette, actively smoke it, etc. You can have a lot of nicotine in that e-liquid, high concentration, that you just puff on all the time. And so you're getting exposed to a lot of nicotine. So there's a lot of nicotine in that liquid, which from a commercial perspective is good for the makers of the products because, again, they've got customers who are now hooked on their product. But from a public health perspective can be challenges for, like, in this case, children getting into the liquid.
Okay, thank you very much. Trayvon.
Dr. Hassan Abalushi, board-certified emergency physician from Oman, is accepted, I understand, to Emory for fellowship and is passion in toxicology and education and is going to come forth to the discussion on beta blockers and cocaine use. Thank you.
Thank you for the introduction. Assalamu alaikum. Good morning. So my talk will be about beta blockers, cocaine-associated chest pain, and the unopposed alpha stimulation. So to start with, how many of you are supporting the idea of starting beta blocker and cocaine-associated chest pain? Seems we are done. Okay, so how many of you are against it? 2, 3? Okay, how many of you have no idea what we are talking about? Good, that's what I want. Okay, so to start with, I have no conflicts of interest. And during this talk, we'll review the role of beta blocker in acute coronary syndrome, and we'll review the mechanism of cocaine-associated chest pain. Then we'll examine the evidence behind this idea. And at the end, we'll touch on some guidelines and recommendations in the management of cocaine-associated chest pain. So let's go one by one. First, why we need beta blockers in chest pain in general, or in acute coronary syndrome. According to American Heart Association statement in 2014, oral beta blockers should be initiated within the first 24 hours of patient arrival if there are no contraindications. And that was class 1, level B of evidence. And then studies came and they said beta blockers therapy reduces infarct size and risk of mortality if it was started early in the course of the disease. Good? So we'll shift a little bit to talk about the mechanism of action of cocaine, then we'll gather them together. So cocaine has 3 main mechanisms of action. One of the most important mechanisms is this one, which is it prevents the reuptake of dopamine and other catecholamines from the synaptic cleft. So as you see in this diagram, dopamine and catecholamines will go and act in the postsynaptic membrane, and then will go back through the dopamine reuptake transporter to the cell to be degraded by monoamine oxidase. What cocaine does, it inhibits the reuptake or the dopamine reuptake transporter, leading to a surge of catecholamines and dopamine in the synaptic cleft. This surge of catecholamines in the synaptic cleft will go and act or overact or overstimulate alpha and beta receptors. By stimulating the alpha receptors, as you can see, it's causing smooth muscle contraction. And by stimulating the beta receptors, we are ending up having smooth muscle relaxation that opposes the effect of alpha receptors. So simply by blocking the beta receptors, we are ending up having unopposed stimulation of the alpha receptors. So that's the issue theoretically, but we need evidence. Let's go through the evidence. Actually, this issue started many years back. In 1990, Lang et al. Did a prospective randomized double-blind control study and imagine having an RCT or experimental RCT in toxicology. That's very rare. So he got 30 patients, volunteers, who are undergoing cath lab for chest pain. And they exposed them, one group was exposed to intranasal cocaine, the other group exposed to placebo saline. Both groups were injected with beta blockers, propranolol. And they found that cocaine group had more increase in arterial pressure, myocardial oxygen demand, and coronary vascular resistance. So that supports the idea of beta blocker causing unopposed alpha stimulation. They conclude that beta blocker use should be avoided in early phases of treatment while cocaine's effect is still present. Sand et al. 1991, again, they tried esmolol here, which is a selective beta-1 blocker, and they concluded that esmolol reliably decreased heart rate but had an inconsistent effect on blood pressure. After that, 1993, Boyer et al., they used labetalol as being an alpha-1 blocker. And they said they saw that labetalol reduced heart rate, blood pressure, but had no effect on coronary artery cross-sectional area. And they concluded that it might be alpha-1 antagonism unique to labetalol that was responsible for these reported outcomes. Then after that, many case reports have been published supporting this idea, in line with many experimental animal studies as well, supporting the idea of unopposed alpha stimulation. So isn't that enough? And why not we stop here and just avoid beta blocker and cocaine-associated chest pain? That's because many retrospective studies came recently and studying patients who received beta blockers and cocaine-associated chest pain, and they found there was nothing happened with them. So are we overemphasizing the idea of unopposed alpha stimulation? Let's see. We'll go through these studies one by one. I'll just choose some landmark studies of these. So beta blocker for chest pain associated with recent cocaine use. It was a retrospective cohort study involving 331 patients with chest pain and recent cocaine use. 151, or half of them, received beta blocker in the emergency department. And they found that there was no meaningful differences in ECG changes, troponin levels, length of stay, intubation, or death between these two groups. They concluded that beta blockers do not appear to be associated with adverse events in patients with chest pain with recent cocaine use. But the issue with the study, it was a retrospective study, so you cannot control your patients, and they used urine tox screen to detect the use of cocaine. And what's the issue of urine tox screen is that it detects cocaine. Cocaine can be detected in urine up to 48 to 72 hours or even more, so that they are not sure, is this an acute cocaine overdose or no? Which is a big issue, actually. Then, early use of beta blockers in patients with cocaine-associated chest pain. It was also a retrospective review, 378 patients with chest pain and received beta blockers. 28 of them received beta blocker after cocaine abuse. And they found that there was no statistically significant differences between the two groups. So does that mean we are overemphasizing the issue? Let's see. It's a retrospective study again, so you cannot control it. There was no standardized follow-up protocols for the study. And again, the tool that they used to detect cocaine was urine tox screen. So again, the same dilemma. Then there is this meta-analysis of outcomes of beta blockers used in cocaine-associated chest pain. They got 5 studies, around 1,800 subjects, and they found that there was no significant difference on myocardial infarction in patients with cocaine-associated chest pain on beta blockers versus those who didn't receive beta blockers. And there was no significant differences in all-cause mortality as well. They concluded that in patients presenting with acute chest pain and underlying cocaine, beta blocker use does not appear to be associated with an increased risk of MI or all-cause mortality. Again, data derived from these studies were all from retrospective studies. So does that mean there is selection bias? Urine tox screen was the tool they used again. So again, we are in the same issue. and significant heterogeneity between studies included was there. So, again, how many of you will go with beta blocker and cocaine-associated chest pain? No, 2? Okay, how many of you are against it? How many of you are still in between? Good. Okay, so this summary might help you. Physiologic and pharmacological studies or principles suggest that it is contraindicated. Good? Animal studies suggest that, experimental animal studies suggest that it is contraindicated. Case reports said it's contraindicated. Randomized trials, experimental randomized trials in humans suggest that it is contraindicated. Retrospective human studies, questionable. So what do you think now? Against? Okay, good. So bottom line, based on available data, beta blocker use is still not recommended in cocaine-associated chest pain or to be avoided. Further research is needed to fully explain the significance of unopposed alpha stimulation phenomenon, which is difficult, I think. Although beta blockers are recommended for patients with myocardial infarction unrelated to cocaine-associated to cocaine because it can lead to lower mortality risks, death from cocaine-associated chest pain are exceedingly low. So you just weigh it. I like the statement or this diagram from American Heart Association and American Academy of Cardiology, where they said that if you had a patient with cocaine-associated chest pain, avoid beta blockers acutely, and you can start it later in the course of the disease. You consider beta blockers, especially if high-risk features are there. Thank you.
Thank you, Dr. Sen, for a very nice summary of literature and this common problem. And it is supposed to be a debate, so who would like to ask a first question?
Thank you very much for your this nice talk. So we have a new question that we have to ask the patient who have chest pain come to emergency department. And just before here, we always ask about the characteristic of the pain.
Exactly.
For the patient who has chest. Now, there is a new question. We have to ask, did you get cocaine or not? Do you recommend us to ask this question to the patient?
How many of them they'll tell you, and how many of them will tell you when they started? That's the issue. We recommend actually, you ask, but how accurate it will be? I doubt it.
Thanks, Hassan, for an excellent talk. I like his comment. Actually, in young age group, it's actually one of the predictive risk factors for having cardiac events. So we usually ask, and sometimes the way that you want, if you want them really to respond to you nicely, tell them like, it will make me save your life. I'm not like, I'm trying to help you, and I'm just want to make sure that you don't have serious issue regarding the drug. And they will tell you. I remember one of my first case of acute MI, cocaine-induced, you know, his friends brought him, and when we actually were dealing with him seriously and he was rushed to the cath lab initially, they got so scared, and it's like, what did he do? And all of them, they were actually high on cocaine, it seems, and they got scared that all of them actually had told us, okay, we were doing this. Are we going to get the same thing? So it's just like to bring to them, it's something that can actually cause serious effect. We are just trying to help you. They will tell you the information. Fortunately, cocaine is not something common in my country. We don't see it just like once in a while.
Anybody else? I'll have one. So in the US population, at least old data, would say that about 25%, about a quarter of the patients who have evidence of recent cocaine use, again, by a study that doesn't look at its acuity, urine drug screens, will not admit to that, even when confronted with that data. So attitude and asking can make a lot of difference, but and it may be different in different countries, but certainly a good percentage of people are not going to, indicate that they've recently used. And as you demonstrated, a lot of the studies, if you do a meta-analysis of bad studies, you just have a larger number of bad studies to look at, and that isn't necessarily helpful. So how would you want somebody to do a study going forward in terms of, as toxicologists, we should be more involved in some of these external studies that will use the emergency department patients. So what feature would have been important to change from your perspective?
Actually, the best will be experimental studies, but it's difficult in toxicology, as you know. Again, large meta-analysis, more accurate, pooling more studies than rather only retrospective studies. So pooling all the other studies as well, it might help.
If you were going to do a small study or prospectively, we can sometimes work with the laboratory to do some testing that would be more suggestive of recent use. So you can sometimes use the laboratory as a friend rather than just accepting the results. That can sometimes help. But I think some of what you had mentioned, just in terms of letting people know that you're there to help them, you got to tell us the truth. But a lot of the patients with cocaine-associated chest pain are not having an acute coronary syndrome. So for them, those retrospective studies are correct. You could get away with it, but it may not be the best idea if they've actually got an MI and they've had cocaine use within the last few hours. So. Go ahead.
Yeah, I was going to say, would you consider that there may be other reasons to give beta blockers in cocaine toxicity other than chest pain? And in those scenarios, would you consider beta blockers, and which one? Because I accept your data for chest pain, and I don't know what the percentage of people that get chest pain would, off the top of my head. I'm sure it's a significant, but it's not anywhere near 100%, obviously.
Yeah.
But what are your thoughts on
other issues that we can use, that we need to use beta blockers in cocaine-associated, like patients presenting with agitation, hypertension. So beta blockers is one of the choices to relieve this hypertension. So here, and other issues like thyroid storm in line with cocaine. So you need to go ahead with beta blocker to prevent the transformation of thyroxine. The experts here, they recommend phentolamine for beta blocker, for hypertension management, which is an alpha blocker. So we'll avoid the issue of unopposed alpha stimulation. Others also, if that didn't help and the patient went to malignant hypertension, or you can go ahead with nitroglycerin or nitroprusside.
This is more of a comment rather than question, and for all the experts here. I'm not sure if the evidence for beta blocker and cocaine gonna happen the same way that calcium and digoxin happen, where actually the evidence came after people using it unintentionally for people who were in digoxin, and then eventually it turned out to be that, okay, it's safe, people are in digoxin. So I'm not sure if any of these studies were just like screening, kind of drug screen for people who presented with chest pain, and eventually it turned out to be cocaine. I'm not sure if somebody have thought of doing that, or it have been done in literature, because this is what happened to calcium evidence in digoxin. Like, eventually it turned out to be safe because people were doing it, and then later on they figure out, okay, people had digoxin toxicity. So I'm not sure if people presenting with acute chest pain, acute coronary syndrome, and or even an MI, and then they were screened for cocaine and turned out to be positive, and beta blocker was used and there was no effect. I just a thought micros. I'm not sure if anybody came across any of this literature.
That's a reasonable analogy, and maybe in the larger sense as well, right? We looked at our patient population, and 96% of the patients coming in with digoxin toxicity were elderly with some intervening acute illness that led to renal dysfunction or renal, pre-renal state, and they accumulated digoxin. That's a completely different patient population than the acute overdose of digoxin when they're not chronically on it in somebody who has no reason to have altered renal or potassium status. In the former group, which we see 96% of the time, potassium will not harm them. Calcium, I'm sorry, salts will not harm them. I think that's very similar to what we're seeing with cocaine-associated chest pain. 90-some-odd% of those patients do not have an acute coronary syndrome, and beta blockade will not harm them. Their blood pressure may go up some, but they are not harmed. But just as I would not choose to give calcium salts to a 2-year-old who got into grandmother's digoxin, I would not choose to give a beta blocker hour 1 to somebody coming in with white powder around their nose, diaphoretic, having a chest pain with tombstone ST elevations, because you're now selecting, much as you said with risk-benefit analysis, you're now selecting the group that would be most likely to have the most adverse outcome, and then you're testing it. And generally, we don't like doing provocative tests with patients. But I think that's a very good analogy in that way. And the guidelines, I think, are appropriate. Early use of beta blocker, like the first thing you do, probably not a good idea if you really think this is an acute coronary syndrome associated with cocaine. But 4 hours later, when the cocaine is gone and cleared from the system, maybe a good idea.
Particularly, as you mentioned, for things like a hypertensive crisis or palpitations that are just not settling down, not an acute dysrhythmia, but palpitations and tachycardia. We've certainly used labetalol in those kind of situations where they have a hypertensive crisis. It's not in the acute phase, it's kind of a little bit settled down. They're not having ST elevation. We've had experience in Australia using that, but they're isolated cases and not. I think it's going to be difficult to have a prospective study where you are choosing that low-risk population to give it to, particularly in a place like Australia where we don't see a lot of cocaine anyway. Thank you. From Turkey. This is Dr. Umut Ocak. He is an emergency physician in Bursa and also working on clinical and basic sciences research at the University of Wisconsin and Loma Linda University as well. He's going to be talking about prognostic evaluation in carbon monoxide poisoning. Welcome.
Thank you for the presentation. Good morning to all. Today I would like to present prognostic evaluation in carbon monoxide poisoning. And first, let's get to know carbon monoxide. Monoxide is a colorless, odorless, tasteless, and initially non-irritating toxic gas formed by hydrocarbon combustion, and it's very difficult to be detected. Carbon monoxide is flammable, and it's quite toxic to oxygen-breathing organisms, including humans. Here is the layers of Earth's atmosphere. Troposphere is the layer where we live. Carbon monoxide is present in Earth's atmosphere. Carbon monoxide is present in Earth's atmosphere at very low concentrations, but it may be higher in urban areas or enclosed environments, lower in clean air. And carbon monoxide has a typical lifespan of several months in Earth's atmosphere. the gas eventually reacts with oxygen to form carbon dioxide. Actually, carbon monoxide is a natural molecule in human body as a product of hemoglobin catabolism. Volcanoes and the bushfires are the natural, unfortunately, the bushfires are the natural sources of carbon monoxide in Earth's atmosphere. Humans contribute to vast quantities of carbon monoxide to Earth's atmosphere, mostly as a result of automobile emissions, leading to atmospheric carbon monoxide level in typical urban areas are around 10 ppm, which is about 100 times higher than in Earth's atmosphere overall. Carbon monoxide is the most abundant by mass pollutant gas. In areas with heavy traffic, carbon monoxide levels can rise to as high as 50 ppm. There are a lot of other sources of carbon monoxide. As you see, they are all human sources. So, what does carbon monoxide do? Very briefly, carbon monoxide binds to hemoglobin with much greater affinity than oxygen and forms carboxyhemoglobin, resulting in impaired oxygen transport and utilization. The oxygen dissociation curve is shifted to the left. Carbon monoxide binds to myoglobin with about 60 times greater affinity than that of oxygen, and carbon monoxymyoglobin has impaired ability to utilize oxygen, leading to reduced cardiac output and hypotension that may result in brain ischemia. So carbon monoxide has double effect on the heart. The binding of carbon monoxide to cytochrome P450 interferes with aerobic metabolism and efficient ATP synthesis. Cells respond by switching to anaerobic metabolism, causing anoxia, lactic acidosis, and eventual cell death. Carbon monoxide may cause leukocyte-mediated inflammatory changes in the brain, leading to CNS lipid peroxidation and delayed neurologic sequelae. Following severe intoxication, patients may display CNS pathologies such as white matter demyelination, leading to edema and focal areas of necrosis. Carbon monoxide poisoning is a worldwide health problem. For example, fire-related smoke inhalation is responsible for most cases of carbon monoxide poisoning, and non-fire-related carbon monoxide poisoning is one of the leading causes of poisoning death in the United States. And non-fire-related carbon monoxide poisoning likely causes around 400 deaths annually, while the number of intentional carbon monoxide poisonings resulting in death is twice as high. Carbon monoxide poisoning is an important public health in my country, Turkey too. We know that most of the incidents occur in winter, and the Middle Anatolian region is of the highest risk in carbon monoxide-related mortality. Carbon monoxide is known as the silent killer, as the signs and symptoms are highly variable and non-specific. So we must always maintain a high index of suspicion for carbon monoxide poisoning. The main findings are cardiovascular and neuropsychiatric symptoms. Acute poisoning may present with different symptoms based on the severity of the poisoning. Chronic carbon monoxide poisoning may be associated with non-specific symptoms as well. After remembering all these, we can start prognostication. And to estimate the prognosis, we must know who is at high risk and who are prone to long-term sequels. The mortality rates of the patients with carbon monoxide poisoning at 1 and 3 months are 1.6% and 5% respectively, and nearly 40% of the survivors have permanent neurocognitive and emotional deficits. Who is at risk for carbon monoxide poisoning? Actually, everyone is at risk for carbon monoxide poisoning. However, some individuals are at higher risk. These are especially people using alternate heat sources during power outages, and elderly, unborn babies, infants, also people with chronic heart disease, anemia or respiratory problems, personnel at fire skins, individuals involved into camping activities, and industrial workers. Many prognostic factors have been studied to predict the prognosis of carbon monoxide poisoning. We will talk about them, and however, very few studies have applied a scoring system which comprehensively evaluates both clinical features and laboratory tests to evaluate carbon monoxide poisoning. The PSS, Poison Severity Score, grades the severity of poisoning according to clinical symptoms in both adults and children. It can be used for different types of poisonings. Here you see the PSS chart, the GI tract, respiratory system, nervous system, cardiovascular system, metabolic status, liver and kidney, blood, muscular system, skin, and the eyes are all evaluated. Although initially it seems complicated, the use of the score is simple. The symptoms are checked against the chart, and the severity grading is assigned by the most severe symptoms or signs observed. I would like to mention another scoring system which is known as SOFA that assesses the severity of a patient's disease by evaluating 6 organ systems which are respiratory, coagulation, liver, cardiovascular, CNS, and renal. It's calculated upon admission and every 24 hours. And in this scoring system, points 3 and above are considered as dysfunction. Although PSS has been studied to evaluate a variety of different poisonings so far, reports on PSS for assessing the prognosis of carbon monoxide poisonings are rare. This is a very recent paper from Korea that revealed a potential role of PSS along with SOFA score in predicting the prognosis following carbon monoxide poisoning. In this study, the PSS and initial SOFA score were calculated at the time of arrival to the ED, and then the second SOFA that was calculated after 24 hours of ED arrival, and the 24-hour delta SOFA score, which was calculated as second SOFA score minus the initial SOFA score, were all found significantly higher in poor outcome group compared to good outcome group. According to this study, all PSS and SOFA scores were significantly higher in poor prognosis group compared to good prognosis group, both on arrival and at 24 hours. The predictive power of SOFA score or PSS were higher than lactate. That is a well-studied contributor to poor prognosis. Also, age, lactic acid levels, and GCS were other contributors of poor prognosis in the study. So how about lactic acid? Lactate is an important marker of tissue hypoxia and responds to several inflammatory mediators. The correlation between serum lactate levels and increased mortality has been shown in septic shock or trauma patients. There are a number of studies supporting the role of serum lactate levels as a prognostic factor in carbon monoxide poisoning. One of the initial studies showed a significant correlation between the plasma lactate concentration and the severity of neurological impairment following poor carbon monoxide poisoning. A more recent study has reported advanced age, altered mental status on admission, leukocytosis, decreased base deficit, hyperglycemia, and increased CK-MB levels together with increased lactate as predictors of poor outcome in patients with carbon monoxide poisoning. The same study reported advanced age, altered mental status on admission, leukocytosis, and increased lactate levels as independent factors associated with medical complications, including cardiac, neurologic, respiratory complications, and death. A more recent study from my country, Turkey, has supported previous findings and suggested initial lactate level as a measure of severe poisoning at admission to the ED. Of course, it should be noted that in poor carbon monoxide poisonings, multiple factors may affect lactate concentration, such as the duration of exposure, delay of treatment, and carbon monoxide-induced cardiac failure. Another study evaluating the outcomes in patients with carbon monoxide poisoning reported that hypothermia, shock, and coma were more common in non-survivors. Also, non-survivors had poorer arterial blood gas profile, as well as renal and liver functions compared to survivors. Carboxyhemoglobin is another one. It does not correlate with the initial severity and outcome of carbon monoxide poisoning. So it's generally not accepted as a predictor of severity, outcome, or mortality. This is for several reasons. For example, carboxyhemoglobin levels are influenced by the concentration of carbon monoxide in the inspired gas, removal from the source of carbon monoxide, delayed sampling after exposure, duration of exposure, and oxygen treatment given prior to the measurement of carboxyhemoglobin levels. How about hyperbaric oxygen therapy? Actually, the literature evidence regarding the effects of HBOT on mortality or morbidity in patients with carbon monoxide poisoning reveal conflicting results. For example, several studies showed that hyperbaric oxygen can prevent the late onset neurological sequelae of carbon monoxide poisoning, reducing the risk of mortality due to acute poisoning. Moreover, a study from Japan showed that the prognosis in the group treated with HBOT was significantly better than that in the group treated with normobaric oxygen. On the other hand, two very recent and important nationwide studies from Taiwan, including more than 20,000 patients, revealed that although HBOT was associated with a lower mortality rate in patients with carbon monoxide poisoning, especially in those who were younger than 20 years and those with acute respiratory failure. The risk for neurological sequelae was higher in patients with carbon monoxide poisoning who received HBOT than in those who did not. The increased risk was most prominent in the first 2 weeks and remained significant up to 6 months later. Then very recently, the effect of hyperbaric oxygen on neurologic sequelae and all-cause mortality in patients with carbon monoxide poisoning was evaluated by a meta-analysis of the 7 available randomized controlled trials. The results of this meta-analysis suggested that hyperbaric oxygen has no significant effects on recovery, moderate sequelae, severe sequelae, all-cause death, asthenia, headache, memory impairment, disturbed sleep, difficulty in concentrating, visual disturbances, behavioral impairment, and resumption of former activity. Moreover, 2-session hyperbaric oxygen increased the risk of memory impairment and difficulty concentrating compared to those who received 1-session HBO. Also, 2-session HBO showed reduced incidence of recovery and increased the risk of moderate sequelae. And metabolic acidosis is another one that contributes to prognosis. Carbon monoxide causes metabolic acidosis by interfering with systemic oxygen transport. And severe metabolic acidosis is associated with mortality. As we all know, delayed neurological sequelae usually develop within some weeks after an initial complete clinical recovery from acute poisoning. Although DNS gradually resolve over the first months, but can be permanent in about 1/4 of cases. These are the signs and symptoms that we can see as delayed neurological sequelae in patients with carbon monoxide poisoning. Although a patient's initial presentation does not predict the development of DNS with certainty, some variables have been shown to be associated to DNS. These are older age, duration of exposure to carbon monoxide, longer time to treatment, transient loss of consciousness, seizures, GCS under 9, coma, abnormal results on early neuropsychometric testing, severe metabolic acidosis, early brain MRI abnormalities, and etc. Previous studies on just a minute. Previous studies on conventional MRI have shown that particularly vulnerable areas of the brain include the cerebral cortex, hippocampus, basal ganglia, cerebellum, and that lesions of the globus pallidus are typically seen in chronic phase of carbon monoxide poisoning.
1 minute, please.
Okay. A recent study has revealed that ABL occurred in nearly 27% of the cases with carbon monoxide poisoning, and globus pallidus lesion was the most common pattern, and 1/3 of the patients had multiple lesions. Although all these parameters were associated with DNS, And here you can see the hyperintense acute brain lesions following carbon monoxide poisoning on diffusion-weighted MRI. So in summary, as I mentioned earlier, there are some conflicting results. However, some variables such as older age, altered mental status, increased lactate level, severe metabolic acidosis are strongly associated with poor outcome. However, the results regarding the role of hyperbaric oxygen treatment and the levels of carboxyhemoglobin are still controversial. On the other hand, the results regarding the use of PSS and SOFA scores or acute brain MRI findings in determining the outcome are promising. Thank you.
Thank you. Any questions or comments? Just in the front here.
Thank you very much, Dr. Umut, for this presentation. Probably it is better to mention pregnant patient in risk groups, especially because the intrauterine fetus is very sensitive to carbon monoxide. Even though they are normal in the initial examination, but it is necessary to follow this patient for a long time. Because as I said, the intrauterine fetus are very, very sensitive to carbon monoxide intoxication. And another thing, I think the poor outcome is related, associated that you mentioned, older age and previous abnormality or diseases. Sometimes, for example, in my city, the city I'm living in now, has the highest rate of the carbon monoxide intoxication. This is Gaziantep. Just a few simple example. A few years ago, we had only one night, over 900 carbon monoxide intoxication. We have some reasons. I will not explain them. Sometimes it is personality. What I mean, for example, 3 people, they sleep in the same room, and the exposure to carbon monoxide intoxication, one is on coma, the other are normal. They bring their friends. But I don't know the reason. Sometimes it depends, it is a personality. They are sleeping in the same room, one is in coma, the second one is moderate, and the third one is normal, totally normal. There is no any problem. And just a question, what do you think about plasmapheresis for the treatment of carbon monoxide intoxication, especially erythrophoresis? Do you have any comment or explanation for this, for treatment?
Actually, it can be helpful, but I think it's still controversial because it depends on the patient's severity. So you can try if the patient is under coma.
Okay, thank you very much.
Thank you. An associate professor of emergency medicine, Ankara City Hospital in Turkey, with, I understand, has the largest ED in Europe. And he's also a member of the Institutional Clinical Research Board at Ankara City Hospital, published more than 50 articles in peer-reviewed journals, and is interested most in ultrasound and toxicology, and he's talking to us today on air pollution and its effect on health. Thank you.
Professor Makki, thank you very much for introduction. Good morning, ladies and gentlemen. Welcome to our country and this amazing city. First, I would like to express my gratitude to the organization and scientific committee of this great conference. It's a big honor for me to speak in here. Today, my topic is emergency department visits related to air pollution. As everybody knows, air pollution is a serious public health problem that we encounter in the world. We treat more than 1.3 million patients in the emergency departments of our country. You heard it correctly. It's true. More than 130 million patients in a year. Our population is 93 million, so it's a huge number. A certain percentage of these patients are critically ill patients, especially in the winter conditions. The diseases related to cardiovascular and respiratory systems are very often. Increasing evidence has demonstrated adverse effects of short-term exposure to air pollutants on the risk of cardiovascular and respiratory diseases. Most previous studies examining short-term associations between ambient air pollution and various health outcomes have measured ambient air pollution on a daily time scale, which provided important information for better understanding the acute health impacts of air pollution. A few recent studies have observed a more acute health effects of air pollution within a few hours of exposure. It's important to assess the hourly health effects of air pollution exposure. By this way, we can obtain important information for future air quality standards at hourly level. Most of monitoring stations measure